Well, good morning. My name is Dr. Tim Hess. I'd like to, on behalf of the Washington Academy of General Dentistry, welcome you to our WAGD Stay Home, Stay Healthy CE series. Very, very excited today. We've got a nice lineup of speakers starting at 10 o'clock this morning with Dr. Leanne Brady. At 1 o'clock this afternoon, Judy K. Massoff, which is, she'll be excellent for the whole team. And then finishing the day off at 3 p.m., we have Dr. Kevin Queechin. So quite a lineup today. Also, tomorrow we continue in with our CE. We have our CPA friends, the Brays, again, going to give us an update on COVID-19 and on relief provisions and what to do to get back in business by May 18th. So please, if you've been on those webinars before, join us again. That's great information, and we thank them for doing that. So the information is coming through on the flyers here. Please, you can use the QR codes to register for those events. We would like to thank our sponsors, the Washington Academy of General Dentistry, the University of Washington AGD Student Chapter, Comet USA, Seattle King County Dental Society, the University of Washington School of Dentistry, CE, Pierce County Dental Society, Snohomish County Dental Society, and Patterson Dental. Not to forget our friends who have joined us from the Great White North there, the Canadian Academy of Restorative Dentists and Prosthodontics. I'm a big fan of that group. I am a member. So today, please use the chat feature if you want to say good job or those type of things to Dr. Brady. If you have questions that you would like her to answer, please use the Q&A feature. We're not going to use the hands up feature on this Zoom webinar. So please use the Q&A, and as we get to the end of her presentation, then we'll read off those questions for Dr. Brady. You'll see that there's a slide that says CE information. We will be sending you CE verification in the next day or two. Please keep a copy for your records. If you're an AGD member, we will report your AGD CE to the AGD on your behalf, but that probably won't be recorded on your transcript for at least 2 weeks, probably 4 weeks. So please do not send us an email or put in the chat box, when do I receive my CE? It's going to take some time. The AGD is a fantastic organization that I've been involved with for many years. I was introduced to it largely because of Dr. Hayamoto, who's a great mentor of mine, and he's a panelist here today representing the WAGD. I would encourage you, if you're not an AGD member, consider signing up. It's a great organization, and if you're new to dentistry, if you're 1 year out of dental school, I believe the membership dues are only $78. So that's pretty inexpensive to be a member of an organization that's really focused on continuing education and the advancement of general dentists here in North America. So we're getting close to the hour here. Reminder, just if you want to register for any of these events coming up, use the QR code. We do have an event Saturday, August 15th, that's really focused on young clinicians and dental students. And that's the Crown Preparation 101 from analog to digital course that we do. This will be our third time doing this presentation. We had to move it, obviously, because of the COVID-19 issues, but that will be Saturday, August 15th. We've tried to keep the costs down as low as possible to basically pay for a lunch, and that's about it. So as we're moving towards Dr. Brady's time here, just going to take a look. Good. We've got over 480 people that have logged on. We have 920 some registered. And so we'll just kind of give them a little bit of time to jump on. A lot of people think when we mean 10 o'clock, we mean 10 o'clock sharp, and I appreciate that. But with these webinars, we'll always allow you to jump on about 5 to 10 minutes early so you can get settled in. You can check your web camera and your make sure everything's functioning for you. So, well, it's 10 o'clock. And so it gives me great pleasure to introduce Dr. Leanne Brady. Leanne Brady is a privately practicing dentist and a nationally recognized educator, lecturer, and author. With an extensive history in leadership, she is currently director of the education of Pankey Institute. Dr. Brady has developed a vast library of online instruction at leannebrady.com and restorativenation.com. She practices in Glendale, Arizona, is a member of the editorial board for the Journal of Cosmetic Dentistry, Inside Dentistry, and Dental Town magazine. It truly is a pleasure to introduce Dr. Brady. When we reached out to her and told her we were trying to work on this WAGD Stay Home, Stay Healthy CE series, she said yes. I didn't even have to drop the bomb that there's no honorariums for any of our speakers that are doing these webinars. So we greatly appreciate that. If there's any other speakers you would like us to ask to present, please go to our Facebook page or send us an email to the washingtonagd.org, and we'll see if we can get those presenters to help us out. With that, I'm going to stop sharing my screen, and I'm going to ask Dr. Brady to please start sharing her screen. And I'd like you to do one more thing for me, Dr. Brady. You know, I'm a big fan of yours. I think I've told you that many a time. I remember the first time I met you. I would like you to share a little bit about Pankey and Restorative Nation with our participants today.
Awesome. Thank you, Tim. It's like a mutual appreciation society because I'm a big fan of yours too. So, and thank you for having me. It's a pleasure to be with everyone. And yeah, and happy to share some other resources. I think what the Washington AGD is doing and so many other organizations right now, while we maybe have a little more time on our hands, we can sit home and learn, go back to our practices even stronger, I think is just phenomenal. And so I'll give you a couple little places for some resources, and that'll also help cover your question, Tim. So one of the things we are going to do today, the topic that we decided was top clinical tips for aesthetic success. I do this program or a version of this program when I lecture all over the place at dental meetings. And we're going to do a kind of a 90-minute version, and I could go on for days. But the premise of this is we're going to change topics pretty quickly. And I'm going to just talk about new materials, new pieces of equipment, new techniques, or maybe something that's tried and true to really help when you're in your practice doing aesthetic procedures. As part of that, because we're going to talk about a lot of materials and a lot of different pieces of equipment, I want to reference Pinterest. I'm not a super big Pinterest fan because up until the recent couple of weeks, I really haven't had time to bake or craft or do anything. But I do use Pinterest as a way to keep a list of all of the materials and small equipment that I use in my practice and that I lecture about. So if you find me on Pinterest and you look at my limited number of boards, there's one called My Favorite Dental Products. Anything that we talk about today will have an image pinned to that board. And if you click on that image, it's going to take you back to one of three places, either the manufacturer's website, so you can get instructions for use and technical specifications or scientific documentation, or to one of the two independent research companies, so either CR or Dental Advisor. Tim mentioned restorativenation.com. Restorative Nation is an online learning community that I've run for several years. If you are looking for more online educational information, it's a great site to join. There's about 400 videos from 2 minutes to 2.5 hours, runs the gamut of topics, clinical dentistry, occlusion, aesthetics, practice management, patient communication. We also have some really active forums where you can connect with other members. And then my leannebrady.com website is my original website, been up for about 12 years, all in written format. It's a blog, totally free. Easiest way to use that is the search bar. Type in any question and it'll bring you up some articles. And then happy to always to talk about the Pankey Institute. It looks like I'm sitting in Masters Hall, which is one of our 2 lectures. That's not actually accurate. I'm in my house in Glendale, Arizona. Not in Key Biscayne, Florida, but the Institute's been offering just top-notch, exceptional clinical education for 50 years. We're in our 51st year. Many of the dentists I know will share with you how transformational their experience was of going and getting a Pankey education. One of the great ways to check us out right now is we're offering free webinars 3 times a week. Monday, Wednesday, Friday at 4 p.m. Eastern, which is 1 p.m. For those of us on the Pacific time zone. Super simple. You can go to pankeygram.org. So pankeygram.org/webinars. And all of our webinars are there. And everything we've already done for the last 3 weeks has been recorded. So it actually lives on our YouTube channel. So you can just go to YouTube and then search for the Pankey Institute, and it will actually bring you up all of the recorded webinars. So lots and lots of great topics if you want to check that out. And of course, when this is all over, highly encourage, come visit us in Miami, Florida. I know it's a long trip from Seattle, Washington, but it is well worth the journey. All right, with that, we're gonna go into our first aesthetic topic, and I wanna just talk a little bit about bonding and cementation. And obviously we could do probably a whole program, an entire half day or day on the topic of bonding and cementation, but I do wanna just hit a couple of things that are sort of high points, places where I get a lot of questions when I talk about this topic. And one of those is this particular category of materials that we all refer to as the CEMs, because most of their brand names end in CEM, C-E-M. So Unisem from 3M kind of established this, this category of materials. We have MaxSem from Kerr, SpeedSem Plus from Ivoclar, GSem Link Ace from GC America, and I could go on and on. I think every manufacturer has something in this category. Most of the time, we actually call these self-adhesive resin cements. Some of the manufacturers refer to them as self-etching, self-priming resin cements. And that really is the crux of the confusion in this category. Because we use self-etching, self-priming in the name, or self-adhesive in the name, because they're made of resin, the question always comes up, am I bonding or is this a cement? And so we will go back and just talk quickly about that differentiation. So when we use the term cement, which when I was in dental school, we actually called those luting agents, what we're saying is that the restoration is being held on the tooth through mechanics. So we've introduced enough mechanical retention form, resistance form, in the way that we've prepped the tooth. The intimacy of the fit of the restoration against that prepped tooth is giving us adequate mechanical retention. So the chemistry, the thing we're going to put between the restoration and the tooth, is actually probably better named a luting agent. It's designed to seal dental tubules, prevent sensitivity, and prevent a small amount of micro leakage, and not to hold the restoration on the tooth. The converse of that is when we use the word bonding. And when we use the word bonding, what we're actually referring to is we're actually going to replace mechanical retention with something called adhesive retention. So what we're saying is we either have limited or no mechanics holding the restoration on the tooth. And so now we're actually going to use a chemical process to hold the restoration on the tooth. And so that background lets us kind of just discuss the difference between these categories of materials. This category of self-adhesive resin cements, they are cements. This is not true bonding. Now, if you want to go to the science, the technical thresholds to say you're bonding is that you get bond strengths to dentin above 19 megapascals. This category of materials is going to give you bond strengths to dentin somewhere between 7 or 8 to 17 megapascals at its maximum, depending upon the technique you use. So we don't cross the scientific threshold for bonding. Therefore, what we're saying is we actually need mechanical retention. And so why did we even come up with this category of materials? I'm going to make up an answer because I'm not a researcher at 3M. I wasn't the person who invented this category, but I'm going to put back together kind of what I think was happening in dentistry. I think several things were happening. We were moving towards monolithic or all ceramic posterior restorations because we had stronger all ceramic materials. Those are translucent, pretty aesthetic materials. And we didn't want to have to put an opaque white cement underneath them like a polycarboxylate, better known as Duralon, a glass ionomer, a zinc phosphate. So in order to get to neutral or translucent, we have to go to resins. And then when we started using resin cements, if you don't create some amount of etching and priming capacity, resins create chronic post-op sensitivity because they don't seal dental tubules. So in order to go to a pretty resin-based cement and not have problems with post-op sensitivity, the manufacturers had to build in just enough etching and priming to seal those tubules, but they didn't do it as a replacement for mechanical retention. And unfortunately, the name of this category has created just an unbelievable amount of confusion amongst clinicians. So the first question people ask me all the time is, do I use something in this category in my office? And the answer is yes. I have CEMs in my office. I use them all the time. Where do I use them? Exactly where they were designed for. I need a cement, so I've got mechanical retention. I've got retention form. I've got resistance form. But I'm working with an all ceramic restorative material that's pretty translucent. I want something pretty and translucent underneath it. I may have supragingival margins, so I don't want a white line from an opaque cement at a supragingival margin. And I'm going to use this category of materials. I do not use this category of materials when I have inadequate mechanical retention and I need adhesive retention. You have to go to a true bonding system, a true adhesive system, when you're going to do an inlay, an onlay, an anterior veneer, even a short posterior crown. We've all run into the situation of prepping a lower second molar. And although I have to say, I'm still old school enough that my favorite would be gold on that short lower second molar. But I actually do still have patients in my practice that are like, nope, I need it tooth colored. And I explain all of that and they want tooth colored. If I've got a short prep, I have inadequate mechanical retention, I need to bond, I'm not going to use this category. So this is a pretty resin-based cement. It allows you to put something pretty under a translucent ceramic restoration, get really easy of use. This is an efficient category of materials, and it also is resin-based, so it's not water soluble. So especially with our all ceramic restoration, sometimes our marginal interface is a little bigger, our gap is a little bigger. This is a non-soluble material. Okay? So when we think about how to use these, there's a whole variety of options. You can use these very simply like a cement. So try your restoration in, adjust your contacts, adjust your occlusion, whatever your process is for trying in a restoration. And when you're ready to go, dry the inside of the crown out with an air water syringe tip, blot the tooth dry with a 2x2, squirt this stuff in the restoration and seat it. You could do it that simply. Now you can also try to improve the bond strengths, because when you do that technique, you're going to get bond strengths of 6 megapascals, 7 megapascals. If you want to increase the ability of this material to seal the dental tubules, improve what you're using the material for, then you're going to follow some additional steps. So you're going to try and adjust contacts, polish, do all of that. Then you're actually going to clean the restoration, and we're going to talk about how to clean the inside of an all ceramic restoration here in a minute. You may actually also want to etch or prepare the inside of the restorative material. You're also going to clean the tooth and get back to a clean surface. For me, the two ways today to really clean a prep to prepare for an indirect restoration are either a little preppy, which is flour of pumice that I've liquefied with pure 2% chlorhexidine, not mouthwash. Mouthwashes have glycerin in them, they have flavorings, they have other ingredients that interfere with our restorative processes. Buy pure 2% chlorhexidine. They sell it as an endodontic irrigant, and wet your preppy and clean the prep of the tooth with a bristle brush or rubber cup in a latch handpiece, or 30 micron aluminum oxide in a chair side air abrasion unit is a great way to make sure that you've gotten rid of all the temporary cement, any residual contamination in the dentin. And when you use this category of materials and you actually prepare the restorative material, we use the word etch, but prepare the restorative material, couple the restorative material with something like silane or MDP, you clean the tooth preparation, you're down to fresh dentin, then you squirt this in the restoration, seat the restoration. Now you're going to actually cure it from the line angles. We call that a quarter cure technique to get this material to a gel phase. You're going to clean up all the excess. You're going to cover all the margins with an oxygen barrier like glycerin, liquid strip, or deox. And then you're going to fully cure for 10 to 20 seconds from every line angle, depending on the manufacturer. If you follow all of those steps, this category of materials will now get you up to about 15, 16, 17 megapascals of bond strength to dentin, depending upon the manufacturer, right? So you've got lots of choices in this category of materials about how you use it. Why would you vary your technique? I would vary my technique somewhat if I was using this when I had less mechanical retention. I still don't need bonding, but I'd like a little more adhesive assistance. I might do all of those steps. Now, truth of it is, in my practice, I do all of those steps. If I'm going to use these materials, I might as well use them and get the maximum bond strength, the maximum dentin adhesion. So I actually do all of those steps, but you do have choices in this category of materials. Let's talk about two specific things that I mentioned that are critical to the technique. One is this idea of a quarter cure technique. A lot of these materials, the instructions say to cure from the buccal and then cure from the lingual. I actually will tell you that's the most frustrating technique to me, because you gel the resin on the buccal and the lingual where it's easy to get to, and you leave the resin liquid underneath the contact, and then you have to have a jackhammer after the stuff has set completely so that you can clean off all that resin. I use the quarter cure technique. I put my light curing unit on the line angle, driving the light under the contact, and I do mesiobuccal, distobuccal, distolingual, mesiolingual. If I leave some uncured resin that doesn't quite gel on the buccal and lingual, if it gets rock hard, how hard is that for me to clean up, right? It's no big deal. Plus, I know it didn't get rock hard. I can always gel it a little bit more if I want to. Most important to gel the resin that's underneath the contact. So that quarter cure technique is really important. The other thing that I want to mention about that is I also said to go back and cover all the margins with glycerin or deox. Every resin-based material has some amount of an air inhibited layer. The thickness of that air or oxygen inhibited layer depends upon filler percentage and chemistry, and there's all sorts of science, okay? But they all have them. And when you're talking about resin-based cements, that oxygen inhibited layer could be as much as 50 microns. If you are not curing every version of a resin-based cement under an oxygen barrier, you could be leaving a 50 micron layer that never polymerizes. The science says it takes less than about 72 hours for that to wash out or be toothbrushed out or to be removed by the acidity of the oral environment. And you now have to have a 50 micron gap right at your marginal interface, which is exactly why you see that brown line of stain at the first hygiene visit. And that's the process that sets up the beginning of the most common reason we replace indirect restorations, which is marginal leakage secondary caries. So every resin-based cement should be cured under an oxygen barrier. And then I actually then went back and said, I quarter cure now for a full cure. One thing to remember about any material that says it's dual cure. Dual cure materials have better physical properties when you get as much light to them as technically possible. Do not allow them to fully self-cure. Get as much light there as you possibly can. Okay? So I'm going to stop and answer 2 questions, and then we're going to go on to the next slide. So self-adhesive resin-based cement, how about leaving it to cure for itself for 10 minutes and then clean it? You can absolutely do that given 2 caveats. What you are preventing is you're preventing the air inhibited layer from being right at the marginal interface. So you're leaving excess out over the margins. So now the air inhibited layer is way out where you're going to clean material. The problem is you got to clean all that material, and I'd much rather take advantage of the gel phase, clean it off super easily and not wait for it to fully polymerize. The other problem, as I said, is that's a self-cure mode you just described. And every dual cure material on the planet ends up with better physical properties at the end if you fully light polymerize it as much as possible. So if you look at flexural strength, fracture toughness, water solubility, all the different physical properties, your resin-based cement will be more durable in the oral environment if you give it as much light as possible. So I'm not a super big fan of self-cure, and especially just buy some glycerin. I buy USP grade glycerin in a gallon jug, pull it up in my own syringes and put it around the margins. All right. So next question was, if you have inadequate retention on a short second molar, I said I recommend bonding. Gold crowns are my preference. Gold crowns don't allow bonding. So if I'm doing a gold crown on a second molar that's short, I actually can get mechanical retention, because on a gold crown, I go right back to, I've been a dentist for 32 years. So I go right back to retention grooves, slots, keyholes. I build in mechanical retention. I can bevel with gold. I can take my margins very thin. And I'm going to fabricate that gold restoration in a way where my micro gap is so small that I've got really good frictional resistance between the gold and the tooth. I don't need to bond that in. Okay. I was talking about a short second molar and you want to do zirconia or you want to do Emax. And now you really can't build in the same mechanics because the glass can't take that stress. And because of the digital interface today, you may not get that kind of an intimate fit. You need to know how your laboratory is producing that. That I would bond if I needed to. Now, with that said, I do want to just point out that we actually do have bonding techniques today that you can apply to metal. I don't know that you need to, but if you were curious about that, we are going to talk about the chemistry that allows you to do that if you had some curiosity around that. And I'll also just point out today, if you're doing gold, you need to understand if your gold restorations are being done using an old school lost wax technique, and you know you're going to get the accurate fits, because gold today can be fabricated digitally. And as soon as you introduce a digital interface, your fits are going to get less and less accurate unless your lab has really refined this beautifully. And you also need to know what kind of material your gold's being made out of. Is it burnishable? I mean, so just like zirconia is not all created equal, gold restorations are not all created equal either. And I am totally saying this in front of Tim Hess, who probably knows 4,000 times more about this than I do. But just, you know, buyer beware, even in the world of gold today. All right. And I'm just making sure none of the rest of these questions are for me. Would self-etching, self-priming resin cements be indicated when there is not enough enamel to bond? Enamel bonding is always better than dentin bonding, but self-etching, self-priming resin cements don't get as good dentin bonds as true adhesive systems or as good of enamel bonds. If you're telling me you're purely bonding to dentin and you need adhesive retention, you have inadequate mechanics, I would not use this category. I would go to a true dual cure resin cement, which we'll talk about here in just a minute. All right, so now let's say you do want to bond. You say, I need true bonding, true full adhesive retention. So the first thing you have to do to get that is you have to prepare the restorative material. Today we do use metal-based restorations, zirconia-based restorations. That's a polycrystalline ceramic. We use true glass ceramic materials, lithium disilicate, feldspar, lucite reinforced, and we also have our resin-based materials. They could be milled resin, or they could be our resin ceramic hybrid materials like Cerasmart and Enamic. So lots of varieties out there. How do we prepare zirconia? Zirconia restorations can only be prepared, or the word etched is what we use, with 30 to 50 micron aluminum oxide. There is no liquid chemistry that etches zirconia for now. There's one trying to get through FDA approval, but at the moment, there is no liquid or chemical that actually etches zirconia. 30 micron aluminum oxide, 1 bar of pressure, which is 15 PSI. And so it's a pretty specific etching protocol. That, by the way, is also how we etch metal. So if you do want to etch metal, we use 30 micron aluminum oxide, and that is also how we etch resin. So if you're doing a pure resin lab fabricated restoration, or what we call the resin ceramic hybrid materials, you etch with 30 micron aluminum oxide. Lithium disilicate, so Emax from Ivoclar, Vivadent, Lyci Press from GC America, is a very specific glass ceramic, and the two manufacturers actually have two different protocols for how to prepare the ceramic. For Emax from Ivoclar Vivadent, it was a very specific hydrofluoric acid etch. It was a 5% hydrofluoric for maximum 20 seconds, and Emax should not look frosty. We're going to talk about a material Ivoclar brought to market specifically because we were in mass over etching our Emax. And when you over etch Emax, it basically pops off the tooth because you've actually damaged the glass beyond the resin infiltration. So that's on the next slide, okay? Feldspar or lucite reinforced, so traditional ceramics, Vita Glass, Empress, Authentic, Design, Noritake, all those brand names. Hydrofluoric acid, 5, 7, 9, 10%, 60 to 120 seconds. Two ways to look at this. You either need to know all this information and be prepared to etch the material in your office, or you need to verify with your laboratory that they're etching the material ahead of time and that they're using the proper protocol. On a ceramic restoration, etched is easy to tell, whether it looks frosty or not. One little drop of water. You put a drop of water on a ceramic restoration that's been etched, the water goes whoop and wicks across the surface almost instantaneously. If it stays like a little droplet, it has not been etched. So you don't need to look for frosty in your Emax. You should be able to tell pretty quickly, okay? All right, so before we move slides, what is the application protocol for glycerin? Easy. Clean up all the excess after you get it to a gel phase, and then cover all the marginal interfaces with glycerin, and then do your final cure. What are some of the important questions to ask your lab regarding these materials? Should you be asking for specific types of gold, Emax, or zirconia? Yes, yes, and yes. I don't have a lot in here today to talk about different materials, but my experience is the information on a laboratory prescription is insufficient to truthfully help the lab know my preferences. There's only one kind of Emax, so Emax as a material is easy, but you might have a preference about the ingot they use. So it comes in lots of translucencies. HT is high translucency, LT is low translucency. If your Emax is coming back to gray or low value, you may want them to move to a more opaque ingot or block. If it's coming back to opaque, you might want them to move to a more translucent, but there's no strength differences. Emax is the same strength across all of the shades. Zirconia is a different thing. There are 3 big categories of zirconia: 3Y, 4Y, 5Y. You don't need to remember that. The general rule is the prettier it is, the weaker it is, right? So the more aesthetic the zirconia, the more translucent the zirconia, the weaker it is. Most of us use zirconia because we want a high strength material. We want something higher strength than lithium disilicate or Emax. There's no place on a laboratory prescription I've ever seen to specify whether you want high strength zirconia, middle strength zirconia, or highly aesthetic low strength zirconia. You need to call your lab and have that conversation. Most of the time, they are making that decision for you. And in the world of gold, for me, I want to know 2 things from my laboratory when I do gold restorations. I want to know if they're still pouring a physical dye using dye spacer and doing a lost wax technique, or if there's a digital piece of their interface. Again, the digital interface may affect the fit of that restoration depending upon how well the lab has tweaked it. I do want to know with my gold restorations the exact alloy they're using, because I do want to understand whether or not that material is burnishable, whether I'm just cementing a gold crown or I'm actually able to do gold the way I learned in dental school, right? So, and that has to do with the specific alloy. So those are the questions I would tell you generally that I would have a conversation with your laboratory, okay? Internal air abrasion on zirconia is safe. Absolutely, it's safe. It's the only way to etch it. By the way, you never etch any other ceramic besides zirconia. If you etch lithium disilicate, Emax, or feldspar or lucite reinforced, you actually are starting the crack propagation. But zirconia is only etched with air abrasion, and it doesn't undergo crack propagation, which is why it's safe, okay? So not contraindicated on zirconia, recommended on zirconia. It is contraindicated on all of the other all ceramic materials. We're gonna actually talk about IvoClean here in a second. So I'll leave that for the next slide. What is the air abrasion? The air abrasion product on the slide is actually from Cavo. So that's Cavo's Rondaflex. I will tell you that's not what I use in my practice anymore. I use an etch device chairside from a company called Grauman Dental, Groman Dental. You can Google them. They only sell one thing. It's these etching devices. They call them the Etch Master or the Prep Master. Invented by a mechanical engineer from South Florida, has nothing to do with dentistry. Don't ask me how he decided to invent an etching device. It is the best chairside etching unit you have ever had. It's $250 to $300, fits in a 3-hole or a 4-hole. The whole handpiece is 2 inches tall, and all the powder comes in pre-filled disposable tips that are color coded so you know what's on the inside. It's just the best chairside air abrasion ever. And by the way, as my disclaimer, I don't get anything for any of the materials, products, equipment that we're talking about. The only thing you shouldn't listen to me about is the Pankey Institute, because I am an employee. So, but yeah, so check out the Etch Master for sure. How about zirconia primers? We're gonna get to primers on the next slide, so I'll see if I get that. What does it mean when you clean up the red etch and there are still bits of red in the restoration? It means you didn't get all of the etchant out. What does the etchant stick to? It sticks to fragments of dye stone that are stuck on the inside of the restoration. It could stick to fragments of debris or dirt. It can stick to old resin if you're trying to etch a restoration after it debonds. So anytime the red etchant sticks on the inside, A, you're not going to bond right there, and B, the color in the etchant only sticks if there's some sort of debris on the inside of the restoration. How do you clean that? If it's dye stone or just gradu, a steamer. If you're doing this stuff in your office, a steamer is an absolutely invaluable laboratory tool. And if you're trying to get resin out of a restoration because it's fallen out of the mouth, the best way, believe it or not, is with a brownie point in a handpiece going at slow speed. If you air abrade, you'll get rid of the resin, but you'll also cause the glass to crack if it's lithium disilicate, feldspar, or lucite reinforced. And the only other way is to throw it back in a ceramics oven, and then there's still a risk of it fracturing. So believe it or not, labor intensive, brownie point, handpiece, slow speed. What's the preferred way to apply the glycerin? We pull the glycerin up into our own little syringes that we buy that have a fuzzy brush tip, and I just cover the entire prep with the glycerin. It's pretty easy. Some people don't like glycerin because it's lower viscosity. I don't mind it. I just put a lot of it on there. What's my thought on Emax crowns with posterior teeth? I guess my thought is I like it because I do it fairly often. I don't think there's any perfect restorative material. I think we need to understand all the indirect materials, and we need to decide in this clinical situation based on this patient's risk factors, what's the best material to use. I use Emax pretty darn routinely on posterior teeth. I use zirconia occasionally on posterior teeth. I still do all gold. Every once in a while, I still do a PFM. So you name it, I do it in my practice. It depends on the clinical situation. All right, is there a spot cure with a light that allows you to skip the glycerin step? No, even if you self-cure, you're gonna get that air inhibited layer. So I know everybody's trying to avoid that little bit of glycerin that costs about 32 cents, but honestly, it will increase the longevity of your indirect restorations unbelievably. How stable is the color of Unisem? All dual cure materials that contain a chemical polymerization agent that is amine based run the risk of color shifting over time. That includes Unisem. There are only 2 or 3 color stable dual cure products currently for sale in the market. And those are GSEM Link Force by GC America, Verilink Esthetic DC from Ivoclar Vivadent, and one of the Panavia products, I think it's V5. However, with that said, how often do I hear clinicians complain about enough of a color shift when they use Unisem that they have to cut restorations off? I don't hear that very often. Now, do I put in translucent anterior restorations with Unisem? I don't, because I'm just not willing to take that risk. So, but there is a risk. Chemically, there is a risk. All right. I think I answered the how do you deal with Emax veneers. It's either a brownie point and a handpiece or send them back to the lab and have them burn out the resin. There's no perfect solution to getting resin out of ceramics, okay? It does not make a difference whether you aerobrate your zirconia in the lab or at the office. And somebody needs to aerobrate it. Now, you don't want to aerobrate it twice. So if the lab aerobrated it, you really shouldn't aerobrate it again, and you don't need to. And either way, we're going to talk about cleaning, okay? A list of these materials, it's all on Pinterest. So go to my Pinterest board, my favorite dental products. So that should handle that one. Yes, you always aerobrate the zirconia. And glycerin, I just buy glycerin in a gallon jug from Shine Medical. So I'm sure everybody and their uncle sells it. I don't use glycerin on direct composites. Why? The air inhibited layer on direct composite is teeny, teeny, tiny because of the filler percentage and because of the photo initiators. So I do know some dentists who do, by the way. I'm not quite OCD enough to put glycerin on my direct composites, but I do know some really incredible aesthetic dentists who do. When would I use PFM versus zirconia in the posterior? You know what? I have a fair number of patients in my practice who are older, who have old PFMs that already have long bevel or finishing lines that are subgingival. It's a combination of restorative dentistry and perio, so I'm doing a perio pros. There are times when I want that very, very fine metal beveled margin, and they want something that looks ceramic. I'll still do PFM. I also will tell you that PFM still has the best connector size when you have a Pontic, and periodically I do still do things with a Pontic. So there are applications for PFM. All right. Since the air inhibited layer is in microns, I'm trying to read this one. Can you layer any transparent barrier over the top? No, truthfully, guys, glycerin is the best way to answer this. Glycerin, or use the liquid strip that actually comes in the kit, okay? Manage gingival bleeding. We're going to talk about that here in just a minute. All right, so let's move forward, okay? So now we've talked about etching sort of the traditional way. What is that new material that Ivoclar invented for Emacs specifically? It's called monobond etch and prime. I cannot tell you what's in this bottle, neither can anyone else, because it is protected by a patent, and they will not tell you what the active chemistry is. But it is what they call a self-etching ceramic primer. So what does that mean? It actually means it replaces 3 steps when it comes to Emacs or lithium disilicate. It replaces the etching step, so the hydrofluoric acid. It replaces the cleaning step, which we're going to talk about here in a second, which is called IvoClean, and it replaces the silane or the primer step. So whether you're using Monobond Plus or True Silane or G Multi Primer or any of the priming. So you get 3 things in one bottle. Monobond Etch and Prime only works on true glass ceramics. That's lithium disilicate, feldspar, and lucite reinforced. It does not work on zirconia. So you cannot put this on zirconia, you cannot put this on metal, and you cannot put this on anything that's resin-based. It only works on true glass ceramics, but it was designed to prevent us from over-etching lithium disilicate. It is a turquoise colored liquid. The way I do it is I put it out in a little dappen dish. I apply it wearing my loops with a micro brush to the inside of the restoration. You do not want to get this on the outside of the restoration, or the resin's going to stick and you are not going to have fun cleaning it up. So you got to be very precise about how you apply this. You need to agitate it for the first 20 seconds of application time, and then you need to let it set a minimum of another 40 seconds for 60 seconds total as a minimum, but you can actually leave it on up to 6 hours and it will never be able to over etch the glass. You can use monobond etch and prime even if the laboratory has already etched the ceramic, and it will not over etch the glass. It's physically incapable of over etching the glass. So I will tell you today in my practice, one of the things I've asked my laboratory is to stop etching my Emacs. Do not etch my Emacs, because it's super difficult for the lab not to over etch. They typically use hydrofluoric acid. They do 40 restorations simultaneously when they're etching. 20 seconds goes by super quickly. And so I know when I'm doing an Emacs-based restoration, I'm going to try it in, adjust my contacts, adjust my occlusion, polish, whatever your protocol is. And then I'm going to do a 60-second application of monobond etch and prime. I'm now etching it. I'm cleaning it, so I don't have to use IvoClean in this situation. And I'm also priming it, so I don't have to use my Monobond Plus. 1 step, 60 seconds, 1 bottle. And I get to do all 3 of those things, and there's no risk of over etching. The other place I use monobond etch and prime is Ivoclar is in the process of trying to get it FDA approved for intraoral use. I'm not sure if it's passed muster yet, but Ivoclar's science is it's safe enough that it should pass FDA clearance for intraoral use. What does that let me do? It lets me use it when I want to put a Invisalign button on a ceramic restoration, or an ortho bracket on a ceramic restoration. It lets me do intraoral porcelain repairs without having to aerobrate or take hydrofluoric in the mouth. It lets me etch the access of an all ceramic crown that had to have endo, so that I really bond that composite to the glass so that I don't get post-operative leakage. So anytime I need to etch, clean, and prime ceramics that's in the mouth, I'm going to use monobond etch and prime. So it's a phenomenal product if you've not tried it. And definitely if you're milling in your office, you should have monobond etch and prime. So you can do this all in one step. All right, so let's say you're not doing monobond etch and prime. So you're doing a zirconia restoration, a resin-based restoration, a metal-based restoration, or your lab etched for you. And so now you have to try the restoration in to adjust contacts, adjust occlusion, make sure your margins fit. Now you need to clean, because even though the restoration was previously etched, it's now been contaminated with saliva, blood, whatever other stuff got on there, and you need to clean. So today, the cleaning solution that we recommend for any and all indirect materials is IvoClean. IvoClean is also a patented protected material from Ivoclar Vivadent. You can use it on any restorative material. It is not designed to put on teeth. I have people ask me this all the time. It does not clean preparations. It cleans restorative material. It's a lavender liquid. Shake the bottle vigorously so that it comes out as a solid lavender color, not streaks of purple and streaks of red. It's a 20-second application, 30 seconds to be safe, and you should actually be rubbing it around and agitating while you're cleaning. If you've used try-in paste, try to wipe as much of the try-in paste out first as you can, then apply your IvoClean. At the end of the 30 seconds, rinse and dry. And so this is what you're going to do for zirconia, metal, resin. And you can do it for glass ceramics if your lab already etched for you. And then you need to follow that with a primer. So there are two priming chemistries today. One is silane. Silane primes all of the traditional glass ceramics. Lithium disilicate, feldspar, lucite reinforced, or MDP. MDP primes the glass ceramics, but it also primes zirconia, metal, and resin. So if you want one bottle, buy what they call a multi-primer. So Monobond Plus, G multi-primer, Bisco makes a multi-primer, Panavium makes a multi-primer. Be careful, if the bottle says ceramic primer, it typically only contains silane, and that won't work on zirconia, metal, or resin. You need MDP for that. So now you're going to apply these. You're going to keep them wet for about 60 seconds, and then you're going to thoroughly dry. So you basically have two protocols. One protocol is etch, clean, prime, and the other protocol is use monobond etch and prime, which does all three things in one step and only works on glass ceramics, lithium disilicate, feldspar, or lucite reinforced, right? All right, and so just checking on my questions again to make sure that I'm sort of caught up. All right, I alluded to using PFM in periopros cases. I've seen studies where zirconia shows better biologic adaptation. I personally struggle with this mentally, as PFM, gold allow for flush margins. What are your thoughts? I've actually seen studies that go both ways. Zirconia is a pretty biologically friendly material, but so are high noble metals. And so when I'm talking PFM, I'm not talking base metal, I'm talking high noble alloys. And I agree with you. I do the metal because I know how intimate I can get that marginal seal. So, but I don't think there's a strict scientific answer one way or the other. How do you deal with masking a dark colored tooth when an all ceramic in the anterior? EMAX shows through. If you've got the material you're going to choose has to depend on the prep color. You're going to use a translucent glass if you have a pretty prep, and then you need a core of some kind that has opaquing capacity if you have an ugly prep. If you're going to use an EMAX core, not monolithic, an EMAX core that's layered with something else, they still make their HO high opacity EMAX, and it's about 85% opaquing. You can go to zirconia, and then you're going to get an opaque core about 92%. You can go again to metal ceramics, 100% opaque. The challenge whenever you introduce a core is you have to have adequate thickness of the restorative material to allow the core and then to allow enough pretty ceramics on the top that your restoration doesn't look opaque. So how much space do you need for restorative material is a math equation. You have to add up the thickness of the core, the thickness of the opaque layer if you need it, and then the thickness of the layering ceramic so that you can get pretty aesthetics on top of it. Is there a decreased efficiency of bonding with monobond etch and prime? No. So the scientific studies show that you get the same bond strengths to the glass as if you're using hydrofluoric acid cleaning and then using monobond plus. So works really well. Describe the step in the bonding sequence for EMAX and when to apply the glycerin. So bonding process for EMAX in my world is going to be try in, adjust context, adjust occlusion, polish everything out of the mouth, 60 seconds of monobond etch and prime, rinse and dry. I am then going to do whatever I do on the tooth. So we haven't talked about what process. Then I'm going to put the resin inside the EMAX. I'm going to seat it. I'm going to check my margins with an Explorer. I'm going to pick up a light and I'm going to quarter cure one light at every line angle. I'm going to then clean up the gel phased resin. I'm going to cover with glycerin, and then I'm going to fully light cure at every line angle. So hopefully that walks you through the steps. All right, I don't understand the next question compared to the 3 separate steps, but maybe I already got it. What's my protocol for closing an implant access? Implant access first gets sealed with Teflon tape and something that's called Teleo Onlay. It's half resin and half wax, and it used to be called Fermit or Fermit N. Once the patients have the restoration in their mouth for 30, 60 days, we know they're not trapping food, its floss is fine, everything's good. If we want to seal it permanently, Teflon tape and composite. Do I etch, silinate, and bond? I actually don't normally, unless the patient has a problem keeping the little composite plug in place. And by the way, I always take a photograph so that I know where the access hole is if I ever have to recover it. And I purposely use a composite that's a slightly different color so that I can identify it. And yeah, I do use Teflon tape. And by the way, my favorite Teflon tape is a yellow Teflon tape that's designed for gas lines, not the white for plumbing lines. It's really, really easy to find if you ever have to drill the composite back out. When cementing intraorally zirconia crown over titanium implant abutment, can you use Monobond and Ivoclean in the mouth? You actually can, if you're really trying to keep that in, because that would really keep it in. So you can use Ivoclean and Monobond Plus in the mouth, but don't put it on tooth structure. Ivoclean doesn't clean enamel or dentin. That's why I said that before. Okay, zirconia you don't etch right. You etch zirconia with 30 micron aluminum oxide at 1 bar pressure or 15 PSI. So if you're bonding zirconia, and we do have a bonding protocol for zirconia, you absolutely, the only way to etch the ceramic is with 30 micron aluminum oxide. What causes color destabilization in resin cements? So the amine initiator is what causes color change over time, okay? You know, why have they not removed them? They've not removed them because when you have an amine chemical initiator, you reach maximum cross-linking, maximum chemical polymerization in 5 to 10 minutes. The replacement dual cure photo initiators that are amine-free take 24 hours to cross-link. And so you can get initial displacement of the restoration. So there are some technique differences depending upon what the chemical polymerization agent is. Now, if you're seeing discoloration and you're seeing it quickly, that's not the amines. That's probably more than anything a hemostatic agent. So if you're using a liquid hemostatic agent, it can react with bacteria in the dental tubules and turn the whole prep dark, and then everything looks dark. That'll happen in weeks to months. The actual color shifting of the resin isn't a week to month phenomenon, it's a year phenomenon. So if you're getting something quick, that's not the chemistry of the dual cure, that's something else in your process. Do PFMs or zirconia do better with bruxism? Well, there's a question no one will ever have an actual answer for. But one of the things to think about is, A, what kind of zirconia? Are you talking about flexural strengths of 500 megapascals or flexural strengths of 1400 megapascals? Because that's the range for zirconia. And then the other thing you have to remember with PFMs is, what did you layer on top of the metal? PFMs don't break because the metal never breaks. The ceramic can break off the metal, and if it's been layered with feldspathic glass, that's a 90 to 110 megapascal flexural strength. So it's a very different failure process when you're talking about monolithic zirconia versus PFM, right? So you are kind of comparing apples and oranges. It's not exactly the same thing. How much does MDP increase the bonding for gold and zirconia? Well, there is no other way to bond to gold or zirconia. And so when we talk about bonding restorations, there's 2 bond strengths. There's the bond strength of the resin to the tooth, and there's the bond strength of the resin to the restorative material. And you know, there is no bond between resin and gold or resin and zirconia if you don't etch and then apply MDP. So if you want to bond, you have to use that chemistry. It's the only chemistry that does that. Does it bond enough to replace mechanical retention is probably the question that we're trying to ask here. And the science today is inconclusive. There are still people in dentistry that will tell you you can't bond zirconia, although more and more and more across the board, our academicians and researchers are saying we do have a reliable bonding protocol to zirconia, but there are still some folks out there you could get on the podium who would tell you they don't believe we can bond zirconia. So there, that's not a yes or no answer. That's read the science and kind of figure out where your comfort zone is. What are your steps for zirconia cementation? 30 micron aluminum oxide etch, try it in, IvoClean 30 seconds, rinse and dry, apply Monobond Plus or any other ceramic primer that contains MDP, wet 60 seconds and dry, and that's how you actually treat the zirconia. Yep, same question, just answered it. So I was told by my lab that Monobond Plus is not needed after using IvoClean for zirconia. It depends, are you bonding or cementing? If you're cementing, if you're gonna clean with IvoClean and then go to a glass ionomer material, you don't need Monobond Plus. If you're gonna clean with IvoClean and go to a SEM and you've got mechanical retention, you don't need Monobond Plus. If you're telling me you're trying to bond that zirconia, you've gotta put some sort of a primer on that zirconia, something that contains MDP. So depends on what your process is. So for Emax, can you use phosphoric acid? Phosphoric acid does not etch Emax. It can be used as an alternative to IvoClean to clean it, but it doesn't etch it. Rinse, dry, apply Curare porcelain primer. So the only question I have in this is that nowhere in this protocol of phosphoric acid, rinse, dry, apply porcelain primer are you telling me that the Emax is etched? So phosphoric acid does not etch Emax, but it used to be used as a cleaner before we have IvoClean. That process would work great if it had already been etched by the laboratory. So I've heard that you can use sodium chloride to clean the phosphates from saliva base instead of products like IvoClean. I do not know the answer to that, so I'm gonna defer because I don't know. How do I seal the access for endo? Simple zirconia crowns. I take out my etch master, I air braid with 30 micron aluminum oxide. I clean it really quickly with IvoClean. I apply Monobond Plus, and then I bond in the composite. So it's no different than bonding a zirconia crown. You're just doing it intraorally. Do I always use Monobond on zirconia even if I have good retention? I actually do, but I'm OCD. And I do, you know, all sorts of steps, but it's not required if you're cementing. You ask me personally, yes, I always put Monobond Plus on my zirconia. I always clean my zirconia. I always etch my zirconia. So that's just me. Can I give a summary from trying in the crown to the finished cementation? I'm going to actually defer that only because that might use up all the rest of our time if I went through every possible iteration of that. And do I prefer to block out a dark prep with opaquer on the prep? I actually don't, because now you're adding on, you're basically bonding to the prep and then bonding restorative material to composite. I would actually prefer to build that into the restoration, but different people have different preferences. I actually do use glass ionomer. I am a really, really big fan of GC's new Fuji Sem Evolve, their new generation glass ionomer. Where do I use glass ionomer? PFMs, all metal restorations. I typically don't use it. When I go to all ceramic, I tend to go to something resin based, but I have used glass ionomer on zirconia if I have really adequate mechanical retention. You know what, I can't tell you what MDP stands for. The M is methyl, but then the D and the P are about 42 letters long. So, so we can Google that if we need to. I Google it periodically, but I never remember it, okay? Awesome, okay, a whole bunch of glass ionomer questions. I think I got those. Okay, let's move on. All right, so now if we're gonna truly bond, we're gonna choose between a light cured resin-based system or a dual cured resin-based system. So if we're going to do a light cured resin-based system, why choose light cured? A, you want unlimited working time. So you want to be able to work as long as possible. B, you want to know there's zero risk potential of color shifting. But in order to use a light cured material, you have to know you can promise me, Scout's honor, you can get adequate light to polymerize the material. Where do I use a light cured only resin cement? Anterior veneers, very, very thin pieces of ceramic is where I use it. Please, 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 when you're doing anterior aesthetic ceramics, use the try-in paste or try-in by coupling the restoration to the tooth. Ceramics looks very different aesthetically when it's tried and dried versus when it's coupled to the tooth. If you have your patients approve veneers or thin anterior ceramics dry, they are going to come back and tell you the restorations are turning gray or turning yellow. Because when the ceramics is dry, it is brighter, whiter, and less chromatic than when it's coupled to the teeth. You can use glycerin as a try-in material. You can use water. I'm kind of like, use the try-in paste. It came in the kit. It's got the same light properties as the resin-based cement. Why not? So just remember, to get a true aesthetic approval, you've got to try them in with try-in paste. So here is my try-in sequence for veneers. So this will give you one of those. When I try restorations, and especially at multiple restorations, I try each restoration in individually first dry, and I make sure the margins fit perfectly. If any one restoration has a marginal defect, they all go back to the laboratory with new impressions. Do not put 2 of 10 restorations in and ask the lab to remake the others, right? So they're either all perfect or they all go back to the laboratory with new records. They all get tried in first dry individually to check margins. Then they get tried in together one at a time to check and adjust contacts. Once I know they're going to go in, I try them all in with try-in paste, and now we do an aesthetic approval. Once we've got an aesthetic approval and we've verified what color we're going to use, they come out of the mouth. If they have not been etched by the laboratory, one step, if they're lithium disilicate, feldspar, or lucite reinforced, 60 seconds of monobond etch and prime, rinse and dry, put them in a little ceramic organizer dish. If they've been etched by the laboratory, I'm going to take them out of the mouth. I'm going to wipe out the try-in paste, and I'm going to do 30 seconds of Ivo Clean, rinse and dry. Then my ceramic primer, thoroughly dry it. You do not light cure ceramic primers. They just have to be thoroughly air dried. And then I'm going to put them in my little ceramic organizer. So that's what I'm going to do to the glass. On the teeth, and now remember I set up the caveat that I'm doing a set of anterior veneers here. Okay, I'm going to etch the teeth. I actually do use phosphoric acid a large majority of the time when I do anterior ceramic veneers, because the majority of my prep is in enamel, and I like phosphoric acid on enamel. So I'm going to do 20-25 seconds phosphoric acid, rinse and dry. Then I'm actually going to apply something that has glutaraldehyde and HEMA in it. I use Gluma from Kulzer, but there's lots of varieties. I apply it with a micro brush, and then I blot it dry. Then I'm going to apply my dentin adhesive. Now, I happen to personally use Variolink Aesthetic Light Cure from Ivoclar Vivadent to put my anterior veneers in. It comes with their Adhes Universal. I apply it, I air thin it. How long do we air thin adhesive? Until you cannot see it wriggling underneath your loops. There's no set amount of time, because I don't know how thick a layer you applied. It shouldn't physically be moving anymore. And then you're done air drying. And then I'm going to fully light cure. And I'm going to do that for each tooth individually. That actually is a recommended sequence with Ivoclar's Adhes Universal. If you're using a different manufacturer, you may need to leave your adhesive uncured. So this is a step you need to know your system, your manufacturer's recommendations. Then here's how I do my veneers. I'm going to pick up tooth number 8. I'm going to hold it in my left hand. I'm a right-handed dentist. I'm going to load cement with my right hand. I'm going to seat 8 with my left hand, set down the resin cement, pick up an Explorer, and check my margins. I'm holding the veneer with my left hand. I'm pressing down toward the gingival margin, and I'm pressing labially to hold it against the tooth so it doesn't displace. Check margins, set my Explorer down, pick up a light curing unit with a 2mm tack tip. I'm going to put that 2mm tip right in the middle labial third of the veneer, and I'm going to turn that light on and off as fast as my finger can hit that button, and I'm going to tack 8. I'm then going to pick up 9, load, seat, check margins, tack. Pick up 7, load, seat, check margins, tack. See where this is going? I seat all my veneers simultaneously. It doesn't matter if I'm doing 2, 4, 6, 8, 14. They all get seated and tacked simultaneously. Once they're all tacked, I pick up a different light curing unit that has a 10mm light guide on it. And now I do a wave cure over the buccal and the lingual and get all that resin to a gel. When it's all to a gel, I pick up an Explorer and I clean all of that excess resin off. If it's too liquid someplace, I pick up a light and I gel it a little bit more, but I get everything off of there in a gel phase. Then I cover all my margins with glycerin, and now I fully cure every tooth, and I do 80 seconds per tooth, 20 in the gingival third, 20 in the middle third, 20 in the incisal third, 20 on the lingual. Now it's all fully cured. I rinse off all the glycerin. I now pick up an instrument called a Montana Jack. It is a super, super sharp, super tiny, super strong hygiene instrument. It is the best tool on the planet to clean up excess resin cement. And I clean up all my margins with a Montana Jack. Then I go back with something called a quick strip, QWIK strip, and I open up all my contacts, and then I floss. Okay. Now, many of you are already having a heart attack because I said I seat all my veneers at once, even if there's 14 of them. The trick is this light guide. I think you can see my mouse moving around. It's a 2mm tack tip. You have to have 2 light curing units, one with a 2mm tip, one with a 10mm tip, and you tack every unit. If you seat 2 at a time, you're operating under the belief that you can hold 2 in place without them moving at 2 at a time. Here's the challenge of 2 at a time. A, you can't actually hold them in place because if you do it that way, you always seat the laterals last and you always have to recheck the contacts before you seat them. The only reason you have to do that is they're not exactly in the same place. And when you do 2 at a time, you have to clean resin, which means you're managing much higher risk of gingival bleeding and contamination than I am doing them all at once. Okay, there are pros and cons to both techniques, but the trick to doing them all at once is a tack tip and learning how to tack. Okay, so that's my sequence for veneers. Now, your other choice is dual cure resin cements, and we use dual cure anytime we're concerned about light polymerization. And as we already talked about, there are 2 kinds of dual cures on the market today. Traditional dual cures still have amine-containing polymerization agents and the new amine-free. If you're using the old school, Reliax Ultimate, Multilink Auto Mix, NX3 from Kerr, Calibra from Dentsply, I can go through all the brands, you've got maximum chemical polymerization in 5 to 10 minutes. You know that because this stuff is hard as rocks to clean up if you don't get it in a gel phase. That means it's okay if the person eats a power bar because they got it in their car on the way back to work because they didn't want food in their teeth before you seeded their restoration. If you're using one of the new amine-free materials, Variolink Aesthetic Dual Cure, GSEM Link Force from Ivoclar, you need to know the chemical polymerization cycle can be up to 24 hours. That means you need to tell the patient, no flossing this tooth for 24 hours, no eating anything sticky or chewy for 24 hours, but you have absolutely no risk of the material color shifting. So you need to kind of pick your system and figure out which one of those you want to go with, okay? So I'm going to kind of go through here really quickly, bear with me and see if I can catch up on the questions. Okay, how do you remove an etched or bonded crown? Wish I had a super simple answer for that. Yeah, I prefer to cut through Emax with a fine diamond. Emax is a very coarse material and it takes the diamonds off the shank. So if you use a fine or an extra fine diamond, you'll go through fewer burrs. Zirconia, I pick up a KS1. If you don't know what a KS1 is, it's a burr that John Coyce and Frank Spear invented. It's sold by Brasser. It's a super coarse burr, cuts like through zirconia like nobody's business. When I cut through them, I hope to God they're cemented, not bonded. If they're cemented, I do a split from buccal to lingual, and then I do a split as far mesial to distal as I can get, and then I put a crown remover in. If they're actually bonded, you're going to take these things off in 222 pieces, or you're just going to prep it off as if it's a virgin tooth and just put a lot of burrs out. There's no super easy answer to that. Wish there was. Do I have the lab etch the intaglio rather than hit it with 30 micron aluminum oxide chairside? For my zirconia, I have my lab etch my zirconia. So my lab does the air abrasion for me on my zirconia. The only stuff I ask my lab not to etch is my lithium disilicate because it's too easy to over etch, and I do it with monobond etch and prime. Is there a try and paste the patient can wear the veneers for a day? Not that I am aware of. That would be great. Try and paste, you can set them up, you can hand them a mirror, but you got to tell them to be careful. I'm not aware of anything that you can send them home for 24 hours and then still get them back off. Are you doing anything to isolate the teeth? Absolutely. Rubber dam, split dam technique. Absolutely. Retraction paste, super common while I'm doing this, or retraction cord. Yeah, you've got to isolate and use all of those isolation techniques. Does my lab use dye spacer for veneer fabrication? Veneers are typically done using a foil. It's not actual dye spacer. So they either use a refractory dye or they use a technique where they put a foil if they're doing hand stacked or layered glass. If they are doing pressed ceramics, then they probably are using dye spacer unless they are, of course, digitizing your impression and doing the whole thing digitally. And of course, if they're milling, then they're just scanning your impression and they're doing this. So there's lots of different techniques for veneer fabrication. It depends. The answer to dye spacer depends upon what technique you're talking about. What is the zirconia cutting burr? It's called a KS1. Letter K from the alphabet, S from the alphabet, 1. KS1. Will there be a recording? I have no idea. Tim, shake your head. Is this recorded? Yes, Tim says this is recorded. I'm going to guess there's going to be instructions at the end on how you can find that recording. Yes, Tim says I am correct. On my website, do I have a video for my veneer cementation process? I actually have several videos on there about veneer preparation, veneer provisionalization, veneer seeding. When you say video, I'm trying to remember if I have actual live video in the operatory of doing a cementation process. I don't think so, but I do have live video on Restorative Nation of prepping for veneers and doing shrink wrap provisionals. How do I prep anterior crowns and veneers so I don't get recession? First, you need to know your sulcus steps before you start to pick up a burr. And you need to understand that anything over 3 millimeter sulcus is highly unstable, and only the last millimeter of the sulcus is truly stable. And then if I'm going subgingival, I prep equigingival first. I place my primary retraction cord, and then I drop my margin to within a millimeter of the base of the sulcus. That's the most stable place to put it if you're thinking you're going to get recession. So I use a very precise preparation technique so I know exactly where my margins are placed. What's the best burrs to adjust contacts occlusion on all ceramic crowns? I adjust with fine diamonds going at slow speed. You do not want to adjust ceramics that can undergo cracks with high speed or coarse diamonds, or use stones. Use the same stones that the laboratory uses in a slow speed handpiece so that you don't create cracks. What do you think about the new cement by Premier? I don't know. I've not used it, so I can't comment. Don't even know what's in it. Do you have issues with excess cement going onto adjacent preps when seeding your veneers all at once? I don't really, and even if you do, it doesn't matter. It's liquid cement and you're about to put resin right down on that tooth anyway. If you're getting a lot of extrusion, you're probably overfilling just a little bit. If the lab air abrades zirconia for you, do you not have to reabrade? True. If it's already been air abraded, you just go to your IvoClean and then your Monobond Plus. You don't need to air abrade again. Best way to move, try and paste, wipe it out as much as possible, and then use IvoClean to get the rest. Which lab do you use for zirconia crowns and veneers? I actually use several different laboratories depending upon what I'm doing, but my primary lab is a lab here in Arizona called Dentech Laboratory. But there's lots and lots of great labs. All right, C course recommendation, safely remove cement trap between veneers after cementation, quick strip, a quick strip. Just pop it out of there with a quick strip and then get it with a Montana jack. Already answered that one. Yes, I use retraction paste. Any tips to prevent Teflon tape from messing with the contact? Pull it super thin. The gift of Teflon tape is it gets thinner and thinner. You have to really, really pull it very snugly so it gets down to microns of thickness. All right, so let's move forward just a little bit. I want to try to get some stuff in about impressions before our time runs out. So, you know, when I think about doing impressions, it might seem silly to talk about it because we do these a bazillion times a day when we're normally in our practices. Except what I know is most laboratory technicians would tell you if there's one thing they want their dentist to get better at, it's impressions. And as many times a day as we do it, it tends to be an area of frustration. And so we think about impressions like, I'll get a better impression if I learn to use better retraction. Like, what cord are you using? Are you using retraction paste? Or it's the impression material. If I switch impression materials, that's going to be the key. The truth is the key to an excellent impression is tissue management. And if you have really, really great tissue management and isolation, you'll get a good impression every single darn time. And it doesn't matter what impression material you use, they're all excellent. So what are some tricks for tissue management? One, I want really, really healthy gingival tissue before I prep the tooth. How do I do that? This is one of my all-time favorite products I've learned about in the last decade. It's called Cervatec Plus from Ivoclar Vivadent. It is the only FDA-approved chlorhexidine varnish. It's actually approved for caries prevention as part of the Canberra protocol. Where do I use it? If I have a patient and I've treatment planned them for restorations and they have bleeding points around that tooth on their perio charting, I'm gonna have my hygienist apply Cervatec Plus around those teeth, or if they're doing the exam in my chair, I'm gonna apply it or have an assistant apply it. You will see the most gorgeous, beautiful tissue 2 to 6 weeks after application of Cervatec Plus you've ever seen in your life. I, by the way, put Cervatec Plus around the margins of every provisional that walks out of my office. And if we do patient-approved provisionals for veneers, we apply a second coat of Cervatec Plus just for good measure. And I see gorgeous, beautiful tissue. So if there's something you can do to manage the tissue other than say to the patient, brush and floss his teeth before you have them on your schedule for the indirect prep, Cervatec Plus is the place to do this. We also do use it for caries prevention. I use it for operculitis, gingival inflammation. It's topical application chlorhexidine. It's a phenomenal product. And then I told you part of how I do tissue management is I never prep subgingivally unless I've retracted first. And so when you prep a chamfer margin, you are using 50% of the diameter of the tip of the burr. When you prep a modified shoulder, you're using 75% of the diameter of the tip of the burr, which means you're going to prep the gingival tissue if you take that burr subgingival. The instant you cut the tissue, it's bleeding, and now you have an isolation and a tissue management nightmare. And so if I'm going to go subgingival, the first thing I do is I prep equigingival. So I've done this crown prep and I've dropped my margin just to the top of the tissue. Now I'm going to place my first retraction cord. This is, by the way, why we do a 2-cord technique. The first cord is designed to be packed, and as you push it gingivally, it pushes the tissue out and down, and now your margin that was equigingival is above the tissue. Now pick up your burr and drop your margin, and you're not going to cut the tissue. Once you have the prep finalized, so now I've got all my reduction, I've polished my prep, now I'm going to place my second cord. That's a 2-cord technique. The first cord pushes the tissue out of the way so that you can prep subgingivally without cutting tissue. The top cord makes a space for flash for impression material. The top cord is designed to be placed gingerly so that it sits right at the margin, and it is only pushing the tissue out away from the tooth by the diameter of the cord. When I place my top cord, I look around and I should be able to see the diameter of this cord all the way around. If I can't see the diameter of the cord, I will not have the right thickness of flash. If the tissue has flopped over the cord, I've placed it too deeply, I pick up a piggy tail explorer and I tease the cord right back up to the top of the tissue so I can see the entire diameter around here. Now, if I place this top cord and I see bleeding, first of all, I use epinephrine impregnated cord. I like a very, very thick, rigid braided cord, not a knitted cord. That's a personal preference, but you use what you like. And I use epi impregnated cord. I never use any iron-based or aluminum chloride-based products in my cord or liquid hemostatic agents. They stain teeth, they stain tissue, they interfere with the set of VPS and polyether impression materials. So epi's a safe bet. But if I've got bleeding right now, I'm gonna pick up retraction paste. I don't use retraction paste for astringent retraction. I use it because they're probably the best hemostatic agents available in dentistry today. They don't interfere with any impression materials. They create great hemostasis. They don't stain teeth. They don't stain tissue. I'm going to inject my retraction paste right on top of my top cord, leave it for 60 seconds, which is long enough for hemostasis, but not long enough for astringent retraction. Rinse it and dry it. And then I'm going to move to my impression, taking my actual impression. So I happen to like 3M's retraction paste. It does not have a fancy name. They just call it retraction paste. They don't make Expasil anymore. Kerr took it off the market and reformulated it. It's called Take One retraction paste now. Premier makes Traxident. Different delivery systems, different viscosities, same active ingredient. So you can pick whichever one of these you want. People ask me all the time, do I retract with a laser? I do have a DECA CO2 laser in my office, but I don't use it for retraction, which they actually call troughing. Laser companies don't say it retracts, it troughs. You are removing tissue. The skill is to remove tissue on the inside of the sulcus without shortening the tissue so that you create recession. I never pick up my laser to do retraction or troughing, but I do it all the time if I've got a gingivectomy as part of my restorative procedure or I have excess tissue. But if you're really good with a laser, you can do it. I've just found I have more control with cord. So people have different choices. Tissue management and retraction are just as important if you're doing virtual impressions as if you're doing analog. Okay, I do both in my office. They have not yet invented a camera that can actually scan through blood, through spit, through gradu on the prep of the tooth. So you need to have exposed your margin. Traditional analog impressions, we want 1 millimeter of flash, 1 millimeter long and 1 millimeter thick. I believe you need the same amount of retraction so your camera can get 1 millimeter past the margin so that you can really cleanly outline your margin and get emergence profile. So the technique I've laid out with preoperative tissue management with Cervitec Plus, a 2-cord technique if I'm going subgingival, and then using retraction paste if I need it for bleeding, I do whether I'm going to pick up my camera or I'm going to pick up a gun with impression material. So works the same way in my hands. And then how do you evaluate an impression? Whether it's digital or it's analog, you need to now look at it and inspect it. Flash is this material that's 1 millimeter thick and 1 millimeter long past your margin. And it needs to be contiguous all the way around. No pulls, no tears, no voids, no places where it looks like you have a double impression, almost like a shadow, okay? And in a traditional analog impression, if you missed it, you start over. You cannot put this same impression back in the mouth and add light body on the prep or in the impression. You'll never seed it fully. That is one of the gifts of digital, is you can go back and scan again and pick up missing data. That doesn't work when you're doing an analog impression. Remember, your lab is going to look at this under 20 power microscopy. You should at least look at it under your loupes, whatever you're using, 3 power, 4 power, 5 power magnification, and make sure that it's appropriate. So good impressions are honestly probably about the best thing you can do to get good fits. The better your fits are, the less you have to worry about how thick your resin gap is going to be and how much, the physical properties of your materials, your resin is going to hold on. So can't stress enough how important it is to get good impressions, okay? And I want to jump to just 1 or 2 slides because I know we're super close on time. Tim, I promise I have a watch in front of me. I'm keeping my eye on the time. But I mentioned shrink wrap provisionals, and shrink wrap provisionals for me are probably the most important thing I learned about doing veneers. This is the best veneer technique, but if you don't know the trick, if you don't know the technique, you are going to do this once and you're going to swear my name in every language you speak, and you are never going to do this again. So the trick is the matrix. And you have to have an exquisitely fabricated 2-stage silicone matrix to fall in love with a shrink wrap veneer technique. And I learned a trick from Todd Snyder. Todd actually practices here in Arizona in the city of Phoenix with me. And he published an article in PPAD 15 years ago. If you want to look it up, it's called a bead line provisional matrix is the name of the article. And it is a vast improvement even over a well-fitting 2-stage matrix. And so I've done Todd's technique ever since then. So what am I going to do? I'm going to start with a stone model of my wax up. If you're not using a wax up, you're replicating the existing teeth, you need a stone model of the existing preoperative condition. You're going to use an instrument called a cleoid discoid, and you're going to use the cleoid end, which is the triangular end. There is a reason it has that name. We don't need to talk about it. But the triangular end, and you're going to put the tip of this triangle, and you're going to put it in this model with the tip right in the gap on the model that represents the free gingival margin. And you are going to cut a 1 millimeter deep trench into that model, holding the tip of this instrument perpendicular to the plane of the model. And then you're going to make your 2-stage matrix. So now on your model that you cut this trench, and by the way, I know you're already thinking you're smarter than Todd Snyder and that you're going to do this with a burr. I promise you I thought the same thing. I tried every alternative way to a hand instrument known to man. It only works with a cleoid discoid, right? Because what you need is this triangular shaped gasket of light body silicone that sits tightly at the neck of every tooth you're about to prep and separates the excess. So you're going to make a silicone matrix on this model. You're going to let it set. You're going to trim it with a blade. And then you're going to load it with light body material, put it back on this model, let it set, and let it trim. That is a 2-stage matrix. A 2-stage matrix is the silicone material relined with light body impression material. A 2-stage matrix is exponentially more accurate than a 1-stage matrix. And when you add this bead line gasket, it is going to mean you have almost no excess bicicle to trim off at the necks of the teeth. No picking up a handpiece, okay? I will refer you, as I said, there's a video of this entire technique and doing it intraorally that lives on Restorative Nation. But if you are doing a lot of veneers or you want to do more veneers, the trick is to learn to do a reliable provisionalization technique that will not be frustrating to you or the patient. And a shrink wrap technique with a bead line provisional matrix is the key. So with that, I'm going to just see in the last 2 minutes whether we have time for a couple of questions. Ivaclar rep told me that if I use Cervatec on the temp, the bonding will be affected. Absolutely not true. Not sure where they heard that, but absolutely not true. There's nothing in Cervatec that will impede bonding. Do I charge for Cervatec Plus? It depends on the application. If I'm putting it around a set of 14 veneer provisionals, I do not ding the person 25 bucks for Cervatec. If we put it on in a hygiene operatory, yes, and you use the same varnish code that you use for fluoride varnish. What millimeter of cord? Most of the time I use a 0 as my primary and a 1 as my top chord. When I do anterior veneers, I typically use a 000 as my primary chord and maybe a double or a single 0 as my top if I have super healthy tissue. What do I do if I have a hard time placing the retraction chord? If you have really, really healthy tissue and you can't place the retraction chord, the chord's probably too big, go to a smaller size. So go to a 0, a 00, a 000. And you also may need smaller tipped placement instruments. I actually find the very, very thin chord placement instruments are much better. I can't use a plastic instrument. It's too thick. So I actually need a chord placing instrument. How do I choose the size of the first chord? I already just told you that, the amount of space available. And I answered that. So lots of chord questions. What kind of cord? I said I use a braided cord, a very rigid braided cord impregnated with epinephrine. Okay, can I apply Cervatec Plus right before taking the impression? I've never done that, and I don't think it would interfere with the impression material, but I'm not sure why it would help you. So I don't. I apply the Cervatec preoperatively so the tissue is healthy the day I prep, and then I apply Cervatec around the margins of the provisional so the tissue is healthy when I bond. So, all right, Tim, I think I'm down to like 20 seconds. So.
Oh, yeah, you're fine, but you spend as much time as you want. We're happy to have you.
So, well, I'm just trying to scroll through here and see if there's any other questions I actually haven't answered. How can you tell if you've broken contact enough between the adjacent teeth? Well, one way is, can you get your chord instrument in there, right? And so I literally just pass my instrument through there. And if I can't get an instrument through buccal to lingual, I need to drop the margin a little bit more. Yes, the lab, absolutely. The lab can do the provisional matrix, no question. Teach them how to do a beadline provisional matrix. They all pretty much already do 2-stage. They're ahead of us for that. Technique for single unit veneer, just what I showed you, shrink wrap. Shrink wrap's the only way to provisionalize a single anterior veneer and expect it to stay on. By the way, I also make my veneer provisional patients a temporary appliance called a quick splint that they sleep in at night that goes over the veneer provisionals. That's also critical in those suckers staying on for a couple of weeks. So, all right, thoughts on triple trays for single units. Triple trays are good at what triple trays are good at. They are really, really good at maximum intercuspal position when the tooth you prepped is not the first tooth on the tray or the last tooth on the tray. They give the laboratory zero information about excursive movements, right, left, protrusive. The lab has to rely on anatomic information to get curve of speed, curve of Wilson, inclined planes. Does it work? Do I use them? Sure. I have patients in my practice who have low risk occlusions, have previously been equilibrated, and I'm going to do a number 19, and my lab understands dental anatomy. I can use a triple tray. If you want the lab to have information on protrusive, right, left, centric occlusion, you got to mount models, and you got to get hinge axis, which means you mount models with a face bow. There's no point in doing full arch impressions if you don't take a face bow, because if you don't have arc of rotation, there's no more information than on a triple tray. So, all right, I think other than that, we're just down to lots of thank yous. So I think people have had enough, Tim.
Yes, well, thank you very much, Dr. Brady. I appreciate it immensely. Again, please, people, help support Dr. Brady because she supported us. Get over to Pankey and take a look at their webinars that they have going on. We purposely tried not to step on your toes on any of those webinars, and sorry if we do make a mistake here or there, but also check out Restorative Nation. That is a great resource out there. A lot of these questions that I see you still have in here, I know Dr. Brady has answered those questions many a time. So with that, I'm going to say to Dr. Brady, thank you very much. I'm going to bring up our PowerPoint there again so people can see.
I'll stop my share. Yep.
Yeah. Oh, yes. Thank you very much. And let's share our screen here. And just a reminder of all the great presentations we have coming up. Don't forget Judy K. Massoff starts her presentation at 1 o'clock this afternoon. That's a great one for your whole team. If you haven't seen her before, you're going to absolutely love her. And then at 3 o'clock this afternoon, another Pankey alumni, Dr. Kevin Queechin, is presenting at 3 o'clock. And just got an announcement, Dr. Bruce Cassius is going to do a lecture for us on Thursday on lasers. So thank you for everybody that's volunteering to do these lectures. Please use those QR codes. You can get registered for these upcoming events. And thank you again to all our sponsors. We'd especially like to welcome the Arkansas AGD, Texas AGD, and California AGD that have stepped up and started to promote us in their areas. So with that, look forward to seeing you at 1 o'clock. And again, if you have any ideas for speakers or anything you'd like to see, please send the email to info@washingtonagd.org. You will be receiving 1.5 hours of CE credit for Dr. Brady's presentation today. So I really appreciate her doing, 90 minutes for us. Very, very kind. Let's see, there was one other thing I wanted to share with everyone. Oh, yes. If you would like to see copies of these videos, YouTube, go to the Washington AGD channel on YouTube. Please subscribe. And as these are being completed, we'll try and get them out within a couple of days for you to share with your friends and your team members. Dr. Brady did a fantastic job today. Love this topic. Dr. Lane Ochi last week did some stuff that's similar. You may want to check him out on our YouTube channel. So with that, I'm just going to say thank you from the Washington Academy General Dentistry. Stay home, stay healthy, CE, and look forward to seeing you at 1 o'clock Pacific Standard Time.